As a doctor, I've been asked to translate the world of behavioural psychology into what you've heard about nudging from my colleagues and how we persuade patients to make healthier choices. So if you can all just put your coffee and donuts to the side, I'll go and get you all a glass of water and an apple to take home with you. I'm the medical director of Nuffield Health, and we're the largest trading charity in the UK. We're known for our 31 independent private hospitals serving patients with consultant-led care, and increasingly for our wellbeing strategy with 51 fitness centres and over 100 corporate employee wellbeing schemes. So the context of my talk really is based on our experience of health assessments, which is now the largest programme outside of the NHS in the UK. Nudge has really become the it word for politicos, and in the charitable sector we've taken note of this because it's clearly some lessons for us to learn. And the Conservatives moved very quickly 2 summers ago to stake their claim on this brand of so-called libertarian paternalism, seeing it as a way for the state to act non-coercively for the greater good. All governments hate the idea of nannying. And this really isn't about self-improvement or about personal development. This is about designing choice environments where people make the choices that are best for them, and as the government now called, the big society. And this is something very much that doctors do every day of the week out there seeing patients. The design of these choice environments should be in the way that is most beneficial to the ones making that choice. And I think in the Nudge book, the first example is given of the school canteen, where the arrangement of the food in the cafeteria determines which order the children actually pick things. So if you put chips first, you're going to get rid of chips. But obviously if you put salad at the front, salad goes first. And as has been described, and as a doctor I know this as well as anybody, that patients are inconsistent. They're not always as well informed as they need to be. And we've all got the human failings of willpower. We can't be bothered to fill out the form to go for a health check, even if it's free. And we forget to cancel subscriptions and sit on the settee eating chocolate when we know that we should be going to the gym or doing Pilates. The modern media would portray us as being virtually incapable of balancing the temptations of today with the rewards of tomorrow. So the psychological concepts really here are twofold. People have two systems, the reflective system and the autonomic system, so-called planners and doers. The planner in me says, tomorrow evening I'm going to go to the gym. But when tomorrow evening arrives, I'm there sat on the settee eating crisps, watching the sport. The planner in me is truly rational and makes choices that are best for me, like opting into health screening, for example. The human side of me makes me forget about it. So nudge can be applied to the principles of choice for many problems in healthcare. And the reason that all of this fits is that clinicians are often in the position of being the choice architect for the patients. And this has been outlined to GPs and doctors in communication models for years. So I think you've got a sore throat. I keep picking on you, but you've got 3 choices. You can either see if this settles down by itself. We can give you some antibiotics that might not work, or we can do some painful blood tests. Patients are often given that choice, and the way that you present those choices as a doctor often informs which way that the patients go. Patients want somebody to signpost the problem in a form that they can relate to. The simplest form for this boils down to ICE, ideas, concerns and expectations. Patients want to know their idea, what do I think is wrong with me? The concern, what am I worried about? And the expectation, what I'm hoping that the doctor's going to do for me. For example, it's the new year, I'd like to go to the doctor for a checkup. I'm worried that family members have had heart attacks in their 50s, and I'm hoping the doctor will give me a cholesterol test. If as a doctor you tick all of those three conditions, you leave with a satisfied patient that's more likely to engage with you and follow your advice or the suggestions. Turning to the Public Health White Paper, there's a long-held commitment to improve public health in a new way, an attempt to reduce the health inequalities. And from the charitable sector, it's really welcome to start to link this thing that charities are starting to do, schools and the workplace. Because today's challenge is much more around health improvement and behavioural change. And perhaps with the ladder interventions and the nudges being described, we're going to encourage people to take more responsibility. I'm just going to finish by giving you a few examples of things that we've tried that have really worked. The first is to make sure the incentive is in line with the outcomes. We know that opt-in schemes only have a participation rate of about 60%, but if you've got to get opt-out, then you retain between 90 and 95%. We acquired a gym chain in the back end of 2007, and with part of our charitable credentials, we introduced a free health MOT. So we went from 0 to 50,000 health assessments in the first year, and that's grown by 15% every year since, because we've introduced a free benefit that is there for everybody as they take up an annual membership. The second thing, help patients to map the outcomes of different alternatives into formats that they can understand. We've all had traditional health assessments where the doctor or nurse tells you to stop smoking, lose weight, and to cut back on the alcohol. Unfortunately, that model doesn't work. We've attempted to change that, and we present to our customers flags based on their conditions, and we give them comparisons for patients of a similar age to themselves, and then ask them to make choices so that they can make their plan. This forms what we call a health score, and by empowering people, we've seen that you get a 2.5% improvement in people's health outcomes just by giving them the required information. The third is to arrange default options to favour better health. I've talked about the health MOT, but by doing that, we've picked up that about 5% of supposedly healthy people joining a gym indeed have some latent health condition that they've not known about. So of the 50,000 people, 5% of those have been picked up with diabetes and high blood pressure that didn't know about it, all by changing the choice framework. There's other examples from the NHS in the States. If you think about paediatricians and immunisations are now the default options, and GPs have to do very little to persuade people to come in to take up these vaccines. I think the government is trying the same with organ donation. Drivers applying for new driving licences from July have to respond to questions under a prompted choice system, and applicants now must register to donate or say that they do not want to answer this question now. The fourth thing is to provide timely and relevant feedback about choices. A patient seeking to lose weight does far better if they're given the information and engaged in the programme so that they do not feel discouraged. And if you think about the traditional weight loss industry, the model is very broken. It's built around failure, in that you don't meet your targets and then you're invited to come back for more coaching sessions and join the group weigh-in. We've changed that model in our weight management programmes and very much give the patients the information so that they can set their own targets, and we're already seeing a more sustained long-term weight loss than's been achieved by some of the previous model. The fifth and sixth are really around, you've got to expect error and develop systems to prevent and detect problems, particularly if people making choices. You can't have people with suspected heart attacks and diabetes not making the right choices without seriously trying to encourage them to have some evidence-based interventions. And the final thing is to structure complex choices to reduce the difficulty of making good decisions. And working with employers, we see that if you provide health schemes and on-site gyms for the workforce, you get an uptake of about 40%, which is much higher than the background of about 12% in the average population. So these things can really make a difference in real life. And probably the greatest challenge that we face is health improvement as a society. The scale of the reform is indeed a really big opportunity for the social enterprise sector. And just a few ideas to leave you with. Perhaps school sports, school dinners, school nursing and health education should be combined to give children wellbeing schemes, a bit like the major corporates have in this country. Perhaps all the screening programmes and wellbeing initiatives should be moved outside of the NHS and given the social enterprise sector a chance to innovate and respond with new solutions. And perhaps we should even think about the national insurance system and think about the incentives for the individual and employers to do the right thing to deliver health-related changes. So just to finish and to borrow from the book that we've all been referring to, as part of this health improvement, we need really to teach you to think about your body like Al Macpherson, to store as much well-being memory as an iPod, and to exercise the willpower of Mahatma Gandhi. Thank you very much.